Very good afternoon to all. So now from research spectrum to the diagnostic testing of NGS. So next 10 minutes I will be talking about what exactly are we doing in our molecular pathology lab. So brief outline is how the molecular testing has evolved, what are the different NGS timelines in our department, and what is our experience pertaining to solid tumors. So I will restrict to the lung cancers. So in this era of precision oncology, after a detailed histopathological examination, every tumor-specific molecular testing is must, and that is important from the clinical management point of view. So over the past few decades, if we just see lung cancer example, we know there have been rapid acceleration in the testing, diagnostic testing, molecular testing, and approval of various targeted therapies. This is the timeline of FDA-approved targeted therapies over a period of last few years, and it is increasing over a period of time. So this is this era of precision medicine, and it is very important to do NGS upfront because of its high throughput, speed, and breadth to identify not just the druggable alteration, but also novel alterations, de novo and acquired resistance mechanism, and that helps us to understand the basic tumor biology. So it is not possible if testing doesn't go hand in hand. So when it comes to testing part, either we have single gene testing or hotspot testing, and now is the trend of comprehensive genomic profiling. So is there any cutoff of number of genes to be tested? No, there is no as such cutoff for number of genes to be tested, but it is basically a testing where you will understand all the different alterations like SNVs, indels, fusions, CNVs, MSI, TMB across different tumors. Then you have small panels, just RNA-based panels, DNA-based panels. So you have to always assess what is your clinical need and do accordingly. So what is happening in the molecular laboratory? So starting from our single gene-based testing, there had been very different testing like multiplexing, and now we do comprehensive panel testing. So in lung cancer, if we see, we started first with just the ALK gene testing in fish from 2013. And then you can see after 2018, there is a decrease in the number of fish cases, and that is because of the ALK IHC was introduced, which is again a predictive marker. Same with ROS fish, if we see, from 2016 we were doing, and then from 2020 there is again a dip in fish testing because ROS IHC came into picture. But for MET amplification, it is just the fish testing that is being done. Then we started with PCR and multiplex testing since 2019, and we were doing easy EGFR kit by Ditech and COBAS EGFR mutation testing. Same timing we started with NGS testing. So these are the different timelines. When 2019 we started, it was Illumina MiSeq with this amplicon-based chemistry for DNA and RNA. In 2020, we started with this SOPHIA panel, and it was a DNA hybrid capture base, which gives more sensitivity and specificity. And we added CNVs and MSI to it. 2020, 21, 22, we added a liquid biopsy and then extended panel with BRCA testing. Now we are doing this extended panel with 55 genes and same CNVs, MSI. Now we have also started this automated NGS testing, and HRD and BRCA testing are now part of this panel, but they are mainly being done in urology, breast and ovarian cancers. So now we'll see what is the molecular spectrum of the routine NGS testing. So in general, we take tumor purity of more than 20%, Phred score Q30 of more than 90% reads, depth of more than 500x, and anything with VAF of more than 5% is considered as positive. And in some cases where tumor purity is less, even less than 5%, and also with some subclonal alterations, less than 5% is significant. Fusion reads in general, more than 5 reads are taken as positive. So if we see both AmpliSeq and SOPHIA STS panel depth of up to 2400x, we have many cases with the same. So when first we analyzed our data till 2021, so out of 1140 cases, 21 were excluded mainly because of the less tumor content, not good quality of DNA or RNA, and 896 were further subjected, and the success rate was around 94%. For NGS testing, it is utmost importance to go for orthogonal testing. So for DNA variants, we usually go for real-time PCR-based testing, and for fusions and CNVs, we make use of IHC and FISH, whichever is available for that target. For MSI, it is usually IHC. So among the variants detected, 86% were clinically relevant, and most commonly it is seen in non-small cell lung carcinoma, followed by head and neck tumors. EGFR, KRAS, BRAF, ALK and ROS were commonly altered in NSCLC. If we see different spectrum, most commonly it is a tier 1, and this is the spectrum of tier 1, tier 2 and tier 3 variants across different solid tumors. Same, if 896, more than 50% belongs to lung, and then second common tumors is GI. So mutant, across the mutant cohort, 62% showed a single somatic mutations, and there were co-occurring alterations in approximately 37%, and this shows the added advantage of NGS over the single gene based testing, in which you will miss all these co-alterations. So this is a oncoprint place plot. So we can see that of NSCLC, out of 350 to around 300 are adenocarcinoma. EGFR is the most common alteration. Fusion seen in 40, and mutation and fusion both in 15 cases. So if you see the distribution across the NSCLC, it is the most common EGFR, followed by TP53 and KRAS. This is the same trend as we see in other studies across Indian subcontinent. Within the EGFR mutation, EGFR exon 19 deletion is 54%, followed by L858R. And then you get a different double mutations of EGFR, different spectrum. Exon 20 insertion comprises approximately 2.2%. This is the different epidemiological details. Again, NSCLC is the most common subtype. ALK positivity with EGFR is seen in approximately 0.8%. Concurrent mutations were seen in more than 60%, and TP53 is the most common, followed by double mutation with EGFR. We also get cases with 3 or more than 3 variants and concurrent mutations along with fusion, of which ALK fusion is always the most common partner. Now next, coming to KRAS, if we see, the most common alteration is G12C followed by G12D. This is again the same as seen in literature, that G12C is the most common alteration in KRAS. Again, concurrence wise, if we see P53 followed by PIK3CA is the most common. So when we see G12C, there is a target available, and if you want to club like G12C versus non-G12C, there is a different histological predilection, because if we see that mucinous differentiation, most of the time you cannot differentiate it from the GI based, and TTF1 is negative, and we usually say that please correlate with imaging finding. This is the spectrum with mucinous lipidic pattern, which is seen in non-G12C, whereas if you see and even PDL1 is negative in that spectrum. And if you just say G12C, most of the times you will have poorly differentiated sarcomatoid morphology, and PDL1 is more than 50% in that spectrum. So this is the current panel, and now we have the CSTS custom panels, 55 genes, where there are new targets which are added. This is the rapid NGS panel testing. So some targets are different. MSI is not included in this. So before you order any panel, we should know what is lacking in that panel, what is the advantages of that panel over the other. So from 2019 to 2024, total 5,587 cases, of which 2,800 belong to lung, and mutation is seen in approximately 75%. Now from Feb of this year, Feb 2024 to June 2024, we have using this automated platform, and around 480 cases have been done by this, of which again 70% belong to the thoracic DMG. This is the same spectrum. If we see, even if we analyze the data at varying time points, it is the same adeno. Okay. So in EGFR, so most common alteration EGFR, second most common TP53, most common CNV, again EGFR amplification, and fusion is EML4 ALK. So this was the paper which was published by our colleague Mamta Gurau. Now there is no point in testing if it is not reflecting into proper clinical management. So this was the paper published by Dr. Kumar Sir's group, the impact of molecular tumor board on clinical management. And any point of, after this NGS testing, all the cases get discussed in molecular tumor board, and any change in the management in the time, like ordering new tests or starting new therapy or enrollment in clinical trial, everything is taken as a change in the management. And if we see that around 60% were recommended a change in the clinical management after the NGS testing and discussion in MTB. Finally, should we get rid of single gene testing completely? Is always a query. So we know the standard of care for molecular testing is too broad and to be adequately covered by SGT. So definitely upfront NGS is the standard of care. But in some cases, there is still in some parts of India where it is not available and tissue is very less, or you want the report in 2 to 3 days, then again, there is a tendency to go for most common alterations like EGFR ALK by PCR or IHC. Second is there any incremental value of doing comprehensive genomic testing over a large gene-based panel? So this was again a study which was published by Sir's group to study the incremental value. In this, around 25 cases in which the same targeted gene panel in-house was done and foundation medicine comprehensive panel testing was done. So out of 25 cases, only in one case, there was a HER2 exon 19 deletion which was captured by foundation medicine. And it was in the exon 19 L855P alteration, which was not included in the in-house targeted panel. And there was one case in which ROS gene alteration fusion was detected in the repeat sample. And the first sample in which targeted was performed was quality was not good and RNA was not performed. So in general, the conclusion was that targeted NGS as a part of routine on-site testing can suffice the clinical needs in the current treatment landscape, especially in the LMIC countries. So with this, I would like to end my talk. Thank you all for patient hearing. Thank you organizers for giving this opportunity. And thank you all. Sorry for overshooting the time.
What is your turnaround time for NGS?
I think, sir, all.
No, you said replacing with a single gene, so I thought let's make a very practical.
I think, sir, if you ask sir, he will be. So with the automated panel, it is, so point is that what happens in TMH, so I agree there is a delay, but what happens at the same time of HPR requisition, the requisition of NGS is raised. So if we, and the actual molecular testing starts after the HPR is finalized. So there is always a delay of more 10 to 12 days in that aspect.
Okay. How much time?
So actually it is like around 4 weeks, 3 to 4 weeks for a MySeq or a NextSeq panel.
4 weeks.
Yes.
So,
automated, it has improved. So around 10 to 14 days, you can say. So 5 days is actually, so if you see GeneXus platform, it is like just you give a nucleic acid and then entire library preparation is automated. The run takes around 3 days. So actually in machine, it takes around 4 to 5 days.
Yeah, but how do you choose which goes on MySeq and which goes on GeneXus?
So actually, we get requisition from the clinicians.
So it is cost-wise different.
So cost-wise, if you see, our cost is around 20,000 for the MySeq panel because more number of samples go in one run.
Okay.
And it is 23,000 for the GeneXus. The point is that if you, for example, take a NextSeq where the output is approximately 500 GB, you can club around 70, 80 samples in one go. But in GeneXus, you don't have that flexibility. So if you are running liquid biopsy in GeneXus, maximum 6 samples we can run in one go.
I completely agree.
Okay, fine. Thank you, ma'am.
Good afternoon.